funding crisis. Thank you. We are happy that you've been able to join us. My name is Peter Morioki. I'll be your overall moderator for the webinar today. To start off, we have two functions that I would like to bring to your attention. The chat function, please, if everyone could introduce themselves in the chat using, you can tell us your name, your institution, if applicable, and the country from which you're tuning in. We would be happy to know you. Number two, the Q&A function, which is below your screen, a few distance from the chat function. Use the Q&A to pose any question to the panelists because of, to anyone as far as the topic for today is concerned. So Q&A for questions and chat for introduction to yourself. You can introduce yourself through the chat function. And I would like to now introduce our moderator for the day. Today's session, which is about naming and framing the issue, is going to be led by Bob, Robert Bob Plum. Professor Bob is the Emeritus William H. Gates Senior Professor, Bloomberg School of Public Health, and the immediate past director, Johns Hopkins Urban Health Institute. He's an author of numerous papers, book chapters, and special reports, and he has served as the president of the Society for Adolescent Medicine and Health, a member of the American Board of Pediatrics, and was the inaugural chair of the National Academy of Sciences Committee on Adolescent Health. Bob has been awarded the Society for Adolescent Medicine Outstanding Achievement Award, the Alpha Herbert Needleman Award for Scientific Achievement and Courageous Advocacy on behalf of children and youth. And in 2014, he received the American Public Health Association Martha May Elliott Award, honoring extraordinary service to mothers and children and adolescents. And in 2023, he was invited to be a scholar in residence at the Rockefeller Foundation's Bellagio Center. Over the past decade, he has served as the principal investigator on a 10-country study of gender norms and their consequences among youth adolescents, that is the Global Early Adolescent Study. And from 2018 to 2023, he co-led a 3-country study on adolescent mental health in Kenya, Indonesia, and Vietnam. Professor Bob, as he is fondly known as Bob, will be our moderator for today. And without much ado, I would like to welcome Bob to proceed. Thank you.
Thank you very much. We're excited about today's discussion. This is not the beginning. It is in the middle of a process that is a critically important process, given the financial crises that we are facing with the massive reductions in international development and support. So the conversation today really is aimed to be a conversation. I would just underscore what Peter Rock was saying. Use the chat. Please put questions, comments, your thoughts, your observations, because we want a dialogue. We are not presuming that we have the answers. We have some questions and we have some ideas. So let me turn it back and let's start in with Caroline and the first presentation.
Thank you very much, Bob. And good morning or good evening or good afternoon, depending on where you are. I am pleased to be sharing some key highlights from the report of the Second Lancet Commission on Adolescent Health as a way to frame the conversation that we'll be having with the panelists. So the Lancet Commission was launched this past May, and please do feel free to scan the QR code to access the report. So building on the first Lancet Commission report, which was launched in 2016, this second report explores the opportunities and challenges facing today's young people, focusing on what we can do to protect and improve their health as we approach the end of the Sustainable Development Goals era. The report is especially timely, given the significant global changes that we are all currently experiencing. Before sharing the highlights, I want to acknowledge the incredible team of commissioners led by co-chairs Professor Sarah Baird, Alex Eze, and Russell Viner, and the many individuals and organizations that contributed to this work. Next, please. Before I share the key messages from the report, I want to highlight an important aspect of how the Commission defines adolescence. Like the first Commission, this report defines adolescents as those aged 10 to 24 years. And this expanded age range is really based on our current understanding of pubertal timing, brain maturation, and social role transitions. So now on to the three key messages. Next slide, please. The first point relates to the sheer size of the adolescent population, which at nearly 2 billion people is the largest generation of adolescents in human history and constitutes about a quarter of the world's population. Next slide, please. We acknowledge that adolescence is a crucial time for development, and investments that are made now can have a huge impact on both young people and future generations. However, the report shows that unless we increase our investments, at least half of the world's adolescents, that is about 1 billion people, will be living in multi-burden countries by the year 2030. These are countries where young people face a complex and excessive burden of disease. Next slide, please. My second point is about funding. The report notes that the resources that are dedicated to adolescent health are nearly not enough to match the scale of the challenge, and they are not being directed to the areas where they are needed the most. For example, between 2016 and 2021, specific funding for adolescent health made up only 2.4% of total development assistance for health. This is a stark contrast to the fact that adolescents themselves account for a quarter of the world's population. This funding gap poses a direct threat to adolescent health and well-being, and as we have the conversation, is something for us to keep in mind. Next slide. Finally, I'd like to highlight the report's recommendations, and it's no surprise that improving the health of adolescents requires collective action from many different groups. It's not just a health issue, it's a societal one that demands significant attention to health inequalities. According to the report, we can improve adolescent health and well-being by many ways, but I just highlight 4 in this slide. The first is around creating an enabling environment to transform adolescent health. This includes having strong national leadership and creating a supportive policy environment. The second is that we need to amplify actions within existing systems or leverage existing systems to address adolescent health and well-being. We need to engage adolescents in the process by ensuring that we are developing innovative approaches to address the complex and emerging threats in partnership with them. And finally, we need to ensure that investments are evidence-based and are adequately resourced. The first point that is highlighted in this slide is particularly pertinent at a time when we are seeing a rise in policy and legal barriers to young people's access to sexual and reproductive health information due to cultural, religious, and political opposition. Next slide, please. Now, I'd like to end with a quote from the report that I hope also forms a call to action. Ultimately, as the report highlights, the investments that we make in this generation of adolescents will determine our human and planetary futures for good or for ill. The time to act is now. Thank you all so much for listening, and over to you, Bob.
Thank you, Caroline, for that incredibly concise and well done presentation on a far reaching report. There are just two things I want to underscore. This report is asking for a change in our definitions of adolescence, that it be expanded to include 10 to 24-year-olds. And that's an important and major change that I hope international organizations pick up. And the second is that data that you presented, 2.4% of investments go to adolescents, where the population accounts for nearly a quarter of the world's population overall. We have a long way to go. Let me turn this over to my long-standing colleague, Dr. Chandra Mooley. Chandra was at WHO and retired after an illustrious career in 2023. He has been a passionate advocate and an extraordinarily articulate advocate for young people and their needs the world over. And he has been recognized for his leadership in the United States by the Society for Adolescent Medicine, the Rotary's International Award for Outstanding Leadership, and the World Association for Sexual Health. He received the gold medal. So let me turn it to you, Chandra. Thank you very much for joining this important conversation.
Thank you, Bob. And thank you, APHRC, for hosting this conversation. Over the last 9 months, the US government, the Trump-led government, has upended international order with devastating consequences to adolescents and other segments of the population in the US and around the world. This disruption is against a backdrop of impressive progress in adolescent sexual and reproductive health and rights in a number of low and middle income countries, but not all of them. There's a real risk that the painstaking process made could unravel. That's the subject of a commentary published in the Journal of Adolescent Health by Bob Blum, by Lucio Ben, and myself. And that commentary is available to anyone who's interested in English and in French. The next slide, please. As I said in the previous slide, a number of low and middle income countries have made tangible progress on adolescent sexual and reproductive health and rights. The Lancet Commission report on adolescent health and well-being that Caroline mentioned stresses that sexual and reproductive health is one of the only areas in which there has been country-level progress in a number of areas of adolescent health that the world has invested in for the last 30 years. In our paper, I've provided examples of Zambia, Moldova, and Nepal. I'm not going to go into this in this presentation. The point to make here is that this happened because of country-level leadership, governments, NGOs, other civil society bodies. But it also happened because of partnerships, partners from outside, funding agencies, technical support agencies, and a number of others contributed to this success. And there's a real risk that this hard-earned progress, the progress that has been achieved with effort and investment, could unravel. The next slide, please. In response to these developments, there's been a flurry of articles by public health leaders from low and middle income countries challenging their political leaders and government officials to do better and more. And I cannot say how thrilled I am that 3 of the authors that we cited in our paper are going to be in this panel to discuss with Bob. So you're going to have them discuss points that we summarized and interpreted for adolescents, because many of their recommendations also apply to adolescents. And in a nutshell, they called for countries to set national priorities. They called for countries to develop strategies to achieve them. And they called for countries to find money from within as far as they can to get local institutions to achieve them. As my friend Lucio Ben, a co-author of the paper, says, you cannot with one breath call for decolonization and with another breath keep calling for sustained investments from outside. The next slide, please. For such change to happen, far must shift from countries, institutions, and individuals in high-income countries to those in low-income countries. This little cartoon is a ChatGPT cartoon that I produced based on what I saw in front of my eyes in the World Health Assembly in May this year in a panel. There was a Ministry of Health official who said, you know, when funders come to the country, they come and we tell them, could you please consider doing this rather than that? They say, oh, we have already decided what we're going to do. And she said, but we are beggars. Beggars can't be choosers. And so we have to allow them to do what they want to do. We have no choice. That has to change. Power has to shift. Next slide, please. Such root and branch change will take time. Meanwhile, low and middle income countries could do much more now. That's the subject of the second webinar. And in the second webinar, we're going to have Julia Bunting from UNFPA speaking with Anthony Ajay from APHRC and a number of low and middle income country governments, which will speak about what they are currently doing given the crisis in front of us. But in a nutshell, what could they do? They could study the available initiatives, the existing initiatives. They could identify in an open and transparent and inclusive manner which ones to protect, and then work with partners from the outside as well as find resources from the inside to protect them. So this is what many countries are beginning to do. My next and last slide. A lot of the papers, including the papers that we have cited, talk about public health and development in general. They don't speak explicitly about adolescent health. And the bottom line is that in the face of this unparalleled crisis, if we don't speak about adolescent health, we will fall off the table. Let's remind ourselves as we go into the panel that in the first 10 years of the MDG era, adolescents were named in the MDG goals, but they were not addressed because there were other burning priorities: maternal mortality, childhood mortality, AIDS deaths in adults. And adolescents were left aside, they were neglected till a movement put them on the agenda in the last 5 years of the MDGs and in the SDG era. So we are shocked, we are saddened, but we cannot afford to be paralyzed and we cannot afford to be silenced. We must get up, regroup, and move ahead. And that's what we're doing here. And I just want to echo what Bob said. We are starting a conversation. We're starting a movement that we all need to join and push ahead forward with. Thank you and namaste.
Thank you, Chandra, for these very important comments. I'd like to briefly introduce now the 3 panelists. And let me just reiterate, this is a conversation. So to have a conversation across the globe with so many people really requires putting comments, thoughts in the chat. I will be integrating what you say into the conversation. But if you don't say anything, there's nothing to integrate. So please join this conversation, because we need you to join this movement to shift the center of gravity to the global south, where the work needs to be and where it belongs and where decision needs to be based. So let me now turn to our illustrious panel. I'd like to introduce Catherine Kiobatongi. Catherine is the executive director of the African Population and Health Research Center, and APHRC is sponsoring this webinar series. Catherine also has been instrumental in speaking out on the role that leadership in the global south needs to play now in the face of these challenges. She is a Ugandan epidemiologist by training. She has had extensive experience in work in medicine, in healthcare management, as well as in epidemiology. She's a fellow of the African Academy of Sciences and more. So, Catherine, thank you for joining. The next person who I will introduce, and actually the first of the three panelists to respond to the discussion we have had, is Gilda Sedge. Gilda is an epidemiologist and is a senior advisor at the Guttmacher Institute, where she has worked for approximately 25 years. She's also been a member of the staff of the Population Council and Pathfinder International. She has a background in epidemiology, demography, international health, and has led numerous global research initiatives. She is also one of the world's experts on abortion, its impacts and consequences. Finally, I'd like to introduce Shashika Bandara. Shashika is a postdoc fellow at McGill University in the School of Population and Global Health. His work focuses on global health policy and governance. He co-leads McGill's research on policy examples addressing structural discrimination to improve health. And he has worked in collaboration with the Lancet Commission on Racism, Structural Discrimination, and Global Health. Shashika is originally from Sri Lanka. So thank you for joining. So let me turn it first to Gilda with both some comments and questions for your consideration, then Shashika, and finally, Catherine.
Oh, great. Hi, thanks, Bob. And great to see everybody here. I have to start by saying how much I appreciate the comments I've been hearing already so far here, and I'm humbled and inspired by them. So the organizers asked us when they brought this panel together to reflect on three main issues. And so I'll begin with a few reflections on them. And like Bob said, this is meant to be a discussion. So this is meant to really be a jumping off point for other people to also share their thoughts on these three issues and more. These three issues or questions are: one, a reflection on priorities for adolescent health and global health going forward. The second one was, what actions should we take as global health practitioners? And the third is, how can we make sure that adolescent sexual and reproductive health remains a priority going forward? So with respect to the first question, global health priorities, including for adolescent health, the organizers asked us to name one priority. And if I had to name only one, I would say primary health care, and especially defragmenting how we invest in and build up primary health care, because development assistance has driven a lot of progress, but we are kind of siloed with different organizations focusing on different health priorities. But primary healthcare is the backbone of so much of healthcare delivery. And if we work together across health priorities, we could strengthen it and address a lot of health-related concerns, including adolescent sexual and reproductive health, cost efficiently. There are other priorities that should really move forward alongside PHC, like countries establishing national health care plans and budgets. And in this year, we have had a lot of important conversations about domestic resource mobilization. And I anticipate that we will see a lot of those conversations turning into action in the year ahead. I will squeeze in one more priority, and that's investing in technologies. Digital technologies and AI happen to be exploding when the money for global health is shrinking. To adolescents is extremely promising. As part of that, we've talked about health literacy. Young people, including young people, need digital literacy and what I would call misinformation resilience in order to be able to differentiate between good and bad information. Especially, I think now, as the anti-rights movement is gaining traction at the same time that funding for adolescent sexual and reproductive health and rights and SRHR more broadly is shrinking. The second question that Bob and the organizers put to us is, what actions should we take as global health practitioners? As a research scientist, I'm going to limit myself to the issue of evidence generation and say that we need new ways to track population health. And we all know that we are facing more or less the demise of the demographic and health surveys, which was a gold standard in tracking many population health needs, including in many countries, adolescent sexual and reproductive health needs. And this is a big challenge. We've been relying on the DHS since the 1980s, but it's also an opportunity. The DHS are kind of clunky, actually, compared to what's possible in the 2020s. And instead of running a new survey every 5 to 6 years in a country, maybe stakeholders who take the lead in this space can create a platform that produces more frequent updates, for example, with rolling samples combined with some kind of model-based inference. And that thought or idea is inspired by Guttmacher's innovations in studying abortion service delivery in the US. So it is not without some foundation or precedent. And that's just one example of how we can think innovatively to build up something new to fill this void. I'm sure there are other ideas out there, and it might be that there's more than one approach that ends up filling this space that would replace the DHS. Whatever shape this takes, the infrastructure should be locally owned. Ideally, the new platform would retain some level of standardization across countries and time, so we can make those comparisons. And Bob and the organizers also really guided us to look ahead rather than look into the past, and look for the positive over the negative to some extent. And my understanding in that context is that not all of the money for the DHS is gone. For every dollar that USAID invested in a given survey, $1.46, so more than half, was leveraged from country governments and from other donors. So we're not necessarily starting from zero in terms of support for the next generation of evidence to support global health, adolescent health, reproductive health, but we need new leadership to step into this space. And then the third question was, how can we ensure that adolescent sexual and reproductive health remains a priority? And to that, my answer, again, this is a discussion, but my answer would be, we need to make the investment case. We've spent a long time elevating the rights-based argument for SRHR, and rightly so, but we have to make sure that advocates and decision makers have access to the investment case. We know through Guttmacher research that every dollar that is spent on contraceptive services for adolescents beyond current levels would save $3.70 in the cost of maternal and newborn and abortion care. And those are just the short-term returns. Adolescent sexual and reproductive health is a development multiplier. When girls and young women can avoid an unintended pregnancy, they can stay in school longer. They can make more substantial contributions to the labor force and the economy, and they are more likely to avoid poverty. We know this. We know that it's a development multiplier. We know that it's the foundation of many other development goals. These points aren't new to us, but we have to emphasize them, and we have to keep building the evidence base on the returns on investment in SRHR, including for adolescents. I was asked to speak for just 5 minutes. I will stop there. I really look forward to hearing other comments and discussion in the course of the hour. Thank you.
Thank you so much, Gilda, because you have really raised some critical issues for discussion, and I want to return to these after we hear from the other two panelists. So let me turn it now to Shashika to comment, reflect on what you've been hearing, to share your thoughts.
Yeah, thanks, Bob. Thank you for the wonderful presentations, Caroline and Chandra. Also, thank you for kicking us off, Gilda. I want to talk about shifting power to the global South. I also want to reflect on the fact that, many of the inequities, including inequities in among adolescents and youth, in terms of health, is sort of symptom of the failures of the system. So we have for a long time been talking about how inequities has affected low and middle income countries. And a lot of the time, the research has been dominated and done by leadership in the high income countries. So one of the shifts, if we have observed closely the last 5 years, one of the shifts that we require is to shift the center of gravity, the agenda setting to the global South. So we can do it in a couple of ways. The first way is to obviously have more representation in the boards and the decision-making processes in organizations. Catherine, the journal that she leads, the PLOS Global Public Health, has done this amazingly well. And then also the Global Health 50-50 report just came out and has said that there's some improvement in this representation sector, but there's ways to go. And the other way I think we should also consider, I know UN is considering moving their headquarters to the UN, to Kenya. We should consider building these centers of gravity, these workplaces in the global South. For 2 reasons. One, then there are opportunities to, in terms of proximity and opportunity to kind of influence the work. And then also, I think we get the chance to move away from a global North-centric perspective. The second thing I would say, which kind of goes as an inevitability of the status quo, is one of the ways that global South leaders and scientists and young people are excluded from the conversation is visa inequity. So we have been speaking about this for a long time. Madhu Pai, Catherine, myself, and so many other young people. But adding on to the visa inequity, if you have followed the news in the last couple of months, you are also realizing how unsafe it is becoming for low and middle income country citizens, immigrants, people who care about equity and so on in the global North. So we wrote this piece about how global North is becoming increasingly unsafe for global health meetings. So we also should try to shift the center of gravity or the meeting places to the global South as well. The third thing I would say is that we require a shift in the way we see global health ideologically as well. So we have to work on ourselves in terms of introspection, but we also have to think about how we educate, how we train our future leaders. So building education centers of excellence in the global south, building more partnerships in terms of equitable partnerships for training is essential. And then incorporating equity within our syllabi, as we have written, as many of us in this panel have written and advocated for, is also essential. So I'm going to stop there, and I'm hopeful that we all can work together and make this happen. This is just a starting point, and hoping to work together with you all. Thank you.
Thank you. And thank you very much, Ashika, for the points that you're raising. We often talk in vague generalities about global equity. We talk about shifting the center of gravity to the global south. But what does that actually mean, and how do you do it? And you pointed the way to some important approaches. And I would certainly applaud the decisions of the United Nations to recenter at least 3 of its major divisions, UNFPA, UNICEF, and UN Women's, to the global south. And I think that is the beginning, not the end, of where we need to go. Let me turn it to Catherine for your comments. I know these are issues of great importance to you and to APHRC.
Yes, thanks a lot, Bob, and thanks for the opportunity to give my reflections about this topic. And it's very difficult to, of course, do justice to this topic in such a short time. So I decided to focus on 2 arguments. And of course, these arguments are aligned to why we're here to begin with. We are in a slightly different context than we were in. I would imagine when the Lancet report was being, the Lancet Commission was underway, and when the report came out, we're in a completely different kind of global environment. And it's not just about the funding cuts, it's about the attack on what I would call the normal. And the normal, I'm putting it in quote unquote, because ultimately is what is normal to who? Because what we see, and I want to keep on talking about we, and I would imagine the people on the call, that what we see as abnormal is not abnormal to everyone. And maybe that's the beginning point of my argument. That at the end of the day, not everybody sees these disruptions as a bad thing, and not everybody thinks that not just the disruptions in funding, but also the anti-rights and the anti-choice movement. Not everybody sees them as a bad thing, including people in the global south, especially the political class. And that based on the statistics that Caroline talked about, the 2.1%, I don't know that it was 2.0 or 2.4%, for 25% of the global population. This is not a new thing. This is something which has always been there. And what has happened in the last few months has sort of exacerbated what was already a difficult and challenging context for adolescent health. And so the thing is that people have been in the field for a long time, know what the challenges are. It's almost like, pushing a rock, a boulder up the hill, trying to gain traction in terms of policy uptake, policy implementation, of course, all these questions about investment. So the first question we need to ask ourselves is, who is we? And from actually Shashika's presentation about shifting power, in my brief with Bob, when I was talking about my remarks, I was like, shifting power to who? Because the focus for us, for we, is about shifting power from maybe global north academics to global south academics. And I want to make the argument that we need to shift power beyond us as academics and shift power to communities, shift power to decision makers, so that there are many more people on the table. I made a comment about how the commission actually was quite impressive in the way they managed to bring in young people in the commission itself as commissioners, and how they brought very valuable contributions to that. We need to go beyond that we involve the communities, we involve government, so that our perspectives do not dominate what we think is the right thing to do. So when I talk about shifting power, yes, we need to shift power from the north to the south, but even to the south, we shouldn't hoard power within the academic spaces that we occupy and assume that we are sort of mandated to make decisions for everybody. So that is the first thing. And the second thing is we need new ways of doing things. And I'll sort of try to find some of those new ways is how do we adopt a system thinking approach? And the system thinking approach actually is not divorced from that whole concept of shifting power. And when I talk about a system thinking approach, there are different frameworks. But one framework that increasingly I find quite persuasive and perhaps is something to give a chance and see where it takes us is the so-called iceberg model. And I find as adolescent health actually being a very good example of how this can be illustrated. And I'll take one aspect of adolescent health, well, just one, because there are many. And if you live in Kenya, you will know that every time when we have the Kenya certificate of primary education exam, we get endless stories of young girls giving birth while doing exams. So we get pictures of these, teenagers sitting in hospitals, holding babies, doing exams, some of them after C-sections. And that becomes something that occupies us and sort of something that consumes us. And once the exam period is over, then we wait for next year, and then we get more stories about young women having birth. So from a system thinking perspective, those are events that capture your imagination, but not for a long time. Now, underlying all that, if you're a scientist, if you're a researcher in this space, you know that there are some trends and data that we have. There are patterns that we know that are underlying what we see during exams. And these patterns are adolescent fertility or teenage pregnancy rates. We know those. We see them and we see whether they're going up, whether they're going down. But for the general public, it's the giving birth to a baby while doing exams. That's what they see. That's what they know. Now, why do we have these trends? We have these trends because we have systems and structures underlying them. And again, as a research and policy organization, I recognize that our effort has been around how to shape the systems and structures, the policies, the strategies, the program design, technical working groups. We focus a lot on the systems and structures that perhaps give us what we see in terms of trends and then give us the events that capture our imagination. What we don't focus on is the mental models that underline those systems and structures. We have so many policies, beautiful ones, beautiful policies. We have a lot of analysis. We know the investment case, we know that. Why is action not being taken the way we want it? It's because there are mental models in society. You have a beautiful policy, it reaches implementation. So the parliament thinks differently. They don't think this is important. They don't think maybe everything that we know works. They don't think that's what we should do. There are mental models, the attitudes and beliefs that people have. And unless we shift those, I think it's very difficult to shift the structures. It's very difficult to address the trends. So my appeal is, in this very difficult environment, that perhaps the new way of doing things is to focus our research and efforts on understanding what the mental models are of decision makers. And perhaps when you're designing programs, instead of designing programs that are touching the structures, that once we move our programs out, the structures collapse, perhaps we should design programs that target the mental models of decision makers so that our parliamentarians, our politicians can actually perhaps see the normal or the abnormal that we see, because our normal and the abnormal are different. And so in this very difficult thing, I would urge that perhaps we need new programs that look at mental models. We need new research that looks at mental models and perhaps focus our efforts on that. And I think from an efficiency perspective, it actually might be something that bears fruit in the longer term than something which addresses structures and processes, and maybe something which addresses patterns and trends without understanding the big part of the iceberg, which is invisible to us. I'll stop there and hope to continue the conversation, not just in the chat, but also in the Q&A. Back to you, Bob.
Thank you. Thank you, Catherine. You've raised many important issues, but one that I would just want to underscore is that we often look outside of ourselves for explanations. And what I hear you say, we have to look inside ourselves. We have to look at how we think about these issues. And just one comment relating to who's at the table. And a point that you and others have made previously is that academics are overvalued, and a lot of other people, adolescents, people who are marginalized in society, their voices are often totally excluded, even if they are the focus of international development. So we need different mindsets, and we need to be having conversations around that. Thank you. This has been very thoughtful and very provocative. I want to turn immediately to comments and questions in the chat. And the first, because it's in the order that I see them, is from Ann Stars. And greetings, Ann. And the point that you raise is adolescents may account for a quarter of the population. What do they account for the GBD, the global burden of disease, and how does that align with the 2.1%? Well, it's an answerable question, but let me make an observation about GBDs. Who defines the global burden of disease? What's a global burden of disease? Let me use one example. In mental health, we use diagnostic criteria, depression, anxiety, PTSD, things like that, to define the global burden of disease. But we know that for young people, loneliness is a major issue and an increasing issue for young people. And that isn't part of the global burden of disease. So there are a lot of conditions that don't rise to the level of disease, that don't get measured. And as you, Gilda, were talking about new information systems, we need a much broader way of thinking about and defining what the burden of the lack of well-being is beyond the quantitative measures. If others have comments, please jump in. Let me turn to two comments, and I'll cluster them together for reflection. These are by Wal Aman. Two thoughts. At a time of restrictive funding, what are the advantages of changing the age group to be more expansive to 10 to 24-year-olds? And are there costs to this sort of change? Secondly, I'd like to raise challenge the thinking for developmental assistance that questions local ownership. I would agree that both are actually symbolic. I don't think it's about asking for donors, but about global solidarity. I see Chandra's point, but can there be both? Chandra, would you like to pick up on that?
Absolutely, and I responded to it in the chat. I fully agree with you, Wale. I think, there are well-intentioned funders and there are funders who work in partnership. But like I said in my short presentation and the image that I shared from an official in the Ministry of Health in a small Southern African country, it's often if a funder pays 75% of the budget, and several UNICEF studies have shown what large proportion of budgets come from funders, there's no equal decision making anymore. It's they who put the money on the table, they who decide what to do, who will do it, where it will be done, how it will be evaluated. We cannot talk with decolonization from one side of the mouth and ask for substantive funding to continue from the other side of the mouth. We have to look for resources from inside, and our government should stop buying helicopter gunships and invest in primary healthcare, like Gilda said. But that doesn't mean that we should completely stop funding that comes in. But it should be ministries of health and governments in the driver's seat to decide how this money is spent with partners like young people in Nepal have shown us. Thank you.
Thank you, Chandra.
I think Shashika has his hand up.
Catherine.
It does indeed.
Yeah, Catherine, go first, and I can go after.
Yes, I mean, I think there's a chicken and egg situation about this. But at some point, there are always these cycles that unless something dramatic happens and we exit those cycles, then the cycles are endless. And we have to ask ourselves, how do we break those cycles? And we might do things that don't break cycles immediately, but maybe 5 years down the line, we actually see how we can exit these cycles of dependency and all that stuff. So I think I'll post a link to a recent paper that I was involved in around what is the starting point, because the system as it has existed has not built structures within the global south that can respond to this sudden shift. So we say let's shift power. It's very difficult to shift power. Let's change funding. It's very difficult to change funding because the systems that could demand the change in funding don't exist. Our schools of public health are not sitting there crunching out numbers and advising government about what is the best way. Do we invest in adolescents? Do we increase the age group? Do we invest in adolescents as opposed to maternal mortality? We don't have those structures. So my beginning point is, as we sit here, again, we, or whoever else is listening, we have to ask ourselves, what are the things we do today that are going to get us out of these cycles that are endless? Because if we keep on doing the easy things, because it's difficult, then 20 years down the line, there'll be another webinar. I don't know, some of us won't be here, but there'll be another webinar talking about, power shifting and all that stuff. We cannot shift power immediately. We have to do things that allow us to shift power. And that means that for the short term, we keep the system that exists, but we start transitioning out of that system. And we define roles for different players in the current ecosystem. If you're a global north scientist, if you're a global north academic, if you're a funder, think about your role. Your role is not to do things in the global south. Your role is to facilitate global south people to do things. If they're not able to do it, then build a capacity for them to do it 3 years down the line or 5 years down the line. But you can't keep on doing things for us. And since we've not had the chance to do it, we don't have the capacity. We need to build the capacity to do things. While we think about transitioning, there are many things which are difficult to see how they can change without an intentional shift in what we see as our role as global health practitioners. And I would say our role is to build capacity right now, start transferring skills, start stepping out and let others step in. There are so many problems in this world. There will be something for all of us to do. So I don't think, I think there's some kind of anxiety that if I build capacity, then I'll lose my, my thing. No, there are so many things to do. Once we finish dealing with adolescent health, we can deal with mental health. Once we finish that, we deal with jiggers or whatever it is. There are so many things to do. So we shouldn't have some kind of anxiety about redundancy and irrelevance. But I think we need to redefine our roles in the whole ecosystem. I'll post the link in the paper. Back to you.
I would just, before I turn it to Shashika, comment and link it with what Chandra was saying. And that is that there clearly is a role for international development. But the role is to help build the infrastructures that allow the capacity for this kind of leadership that we're advocating for, this kind of decision making, to build the capacity to have a much bigger table, to bring those to the table who historically have been disenfranchised. I'll stop at that point. And let me just see this sort of...
Bob, Shashika was waiting to speak.
Yes, Shashika.
Thanks, Chandra and Bob. Catherine, I 100% agree. I just wanted to say that, we create these false dichotomies when we try to build solutions. So, when we say, we have made this argument in our paper about shifting power to the global south and, building allyship. And a lot of the people, when I talk about this, come and say, oh, how can global south do it all alone? I think we have to recognize a lot of the challenges that we're facing in the world right now are global problems, right? They are, to the extent, they're existential problems. If you look at climate crisis and so on and so forth. So, like Catherine mentioned, we have to define roles, but we also have to, especially global North institutions, have to look at the historical role in the inequities that they have created and introspect to the extent that they can recognize the allyship that they can bring. And to the same extent, I think global South leaders, including ourselves, like I'm from Sri Lanka and my conditioning comes from growing up in Sri Lanka, also have to kind of fight against the internalized sort of the colonization mindset that we carry, where we sort of defer the power holder to someone else in the global North. This is something I have had to reflect in different settings, and I think a lot of us go through this. Luchu and I had this conversation too, and I think these are essential steps, and people consider these as soft steps, but I think these are essential steps for us to shift power. And the third thing is that accountability, like how do we hold our governments accountable? In Sri Lanka, I'm active in the space. I know many of us are active in our own countries. In the space of holding our governments accountable in terms of investing in health. I don't think, India did really well in terms of addressing COVID-19 pandemic. I don't think, Sri Lanka just had an economic crisis related protest. So did Bangladesh, so did Nepal. So I think we also have to recognize that there is a lot of work to do together in terms of holding our governments accountable as well. So it's sort of I would say a two-pronged approach at minimum to shift these power and also to address the challenges that we are facing.
Thank you very much. I am very aware of the time. I'm also very aware that we did not conclude this conversation, but we had no intention to conclude this conversation. Our intention was to be part of a conversation that needs to go on in every country, in every donor organization, in all international development efforts within and outside of our countries. And this is part of that really developing a mobilization for, as Sashika says, changing the center of gravity. And as Catherine says, it requires a mindset change as well as a financial investment change. We will be continuing this conversation in a month from now on October 22nd, when we will be hearing from country level leaders on the issues they face and how they are addressing it. Because what we're aiming is for solutions, approaches that we can learn from and pull together. So thank you so much for joining us in this conversation. Again, we will be continuing it next month and the month after.
Thank you all. Once again, many thanks to APHRC for hosting this, and namaste.
Thanks, everyone.
Take care.
Thank
Bye
you. Thanks
now.
to the organizers.
Thank you, everyone.
Thank you, everyone.
Are you still there, Caroline?
We're still here. Can we log out?
I just want to thank you, Caroline, and the team. It was great fun. And thank you, Gilda. Thank you, Ashika. Thank you, Bob. It came together so beautifully.
And to Peter Rock, thank you
And to
for
Peter,
really
Michelle,
steering
Isabella,
this.
Gladys, all of you. Such a wonderful team effort. Exactly just what I had hoped it would be.
Oh, good. That's good to hear.
Yes.
Can I suggest that the next one is 90 minutes instead of 60?
Mm.
60
Or at least
is a very short
maybe
time.
that's right, or an hour 15. Even that extra 15 minutes gives, yeah, without exhausting people, it gives people. There was a lot, Catherine. There was a lot to
We
say.
talked
Yeah.
about
Yeah.
it, Catherine and Gilda. We
I
said
would
that
I would
often
agree
people
with this
step out
suggestion of
in the last
extending the
30
time.
minutes, and there's a big drop in participation. So,
Yes,
but
maybe
we
better
can
to end on a
still
high note. Yeah, go ahead.
reconsider that.
Yeah.
Bye.
Thank
Okay,
you
see you
Good to
next
see
all.
time.
everybody.
Bye-bye.
Wonderful
Bye,
to work
everyone.
together.
Thank you.
Bye.
Bye-bye. Thank you.
Foundation, the local, the worldwide. You go through every now, you're gonna be caked and you're gonna be puffed. Then you take a breath.